Good afternoon. Welcome to the 2015 Bloomberg Manulife event, Are You Fit to the Bone? I'm Jill Barker, Assistant Athletic Director of McGill, fitness columnist for the Montreal Gazette, and today's moderator. I'm once again thrilled to be part of the Bloomberg Manulife event. It's one of those places where we all come together and we can talk about physical activity, and we can learn about physical activities from the leaders around the world, of which we have one today. I'm also thrilled to be in front of another sold-out audience. I think it's 4 years in a row. So yeah, 5 years in a row, excuse me. And this time we're going to be talking about osteoporosis. And the winner of the 2015 winner of the Bloomberg Manulife Prize for the promotion of active health is Dr. Lora Giangregorio, excuse me. And she's here today, and she's going to be talking about bone health. And I'd also like to acknowledge that we have a crowd that is online watching this through our web streaming service. So welcome. So let me go over today's format. And we're going to start with a Q&A of Dr. Lora today. And we're going to, with Ricky Hager. She's a McGill student, and she's one of the beneficiaries of the Bloomberg Manulife Fellowship for the Promotion of Active Health. We'll sit down with Dr. Lora. We'll pose a series of questions related to physical activity and osteoporosis. And when we're done, we'll throw the floor over to you. And then it's your turn to ask your own questions. The goal is, by the end of today, we'll all be more knowledgeable on how to keep our bones strong and healthy as we age. But before we get started, it's my pleasure to introduce the Dean of Education, Professor Dilson Rezier, an advocate for quality science in education. Dr. Rezier is a Canadian Research Chair in the Department of Kinesiology and Physical Education. When he's not working behind a desk in the Dean's office, he's behind a microscope in his muscle and physiology and biophysics lab, aiding in the research of the muscles we use every day. Please join me in welcoming Dean Rezier.
Thank you, Jill. Thank you. And thank you very much for being here, everybody. I'm delighted to be here to introduce this year's prize winner and engaging in what I'm sure will be a fascinating conversation on the latest research related to bone disease and exercise strategies that we can adopt to actually make our bones stronger as we age. So let me just very briefly tell you a bit about this prize. The Bloomberg Manulife Prize seeks, as you probably know, to promote comprehensive solutions to some of the most significant health issues facing our global community, including obesity, inactivity, and poor nutrition. Le prix a été créé afin de veiller à ce que la connaissance ait la capacité d'améliorer nos vies soignants, mise au service des ménages, des écoles et des collectivités, entre autres, et puisse ultimement apporter des changements positifs et concrets dans le mode de vie. Elle vise à mettre d'importantes questions de santé au premier plan du discours public. Elle incite les individus et la collectivité à mettre en œuvre des changements durables et positifs. The prize was established through a generous gift from Lawrence and Francis Bloomberg and Manulife, and is offered each year by McGill University to academics whose research has had or has the impact to have a significant effect, positive effect on the health and well-being of North Americans. But this prize is obviously very competitive. We're very proud to actually have a high-level prize, and part of the success of this prize rests on the quality and the caliber of the jury members. And as in previous years, we're fortunate to benefit from outstanding jury members, and I will just very briefly tell you who they were. Dr. Brian McIntosh is a member of the Department of Kinesiology in the University of Calgary and a president of the movement Exercise is Medicine across Canada. Dr. Christine Williams is the vice president of research and policy at the Canadian Cancer Society. And Dr. Carol Garber is a professor at Columbia University at New York and a past president of the American College for Sports Medicine, likely the largest association that promotes a healthy lifestyle in the world. J'aimerais souligner un autre aspect important du prix, le fonds de la bourse Bloomberg Manulife, qui permettent au département de kinésiologie et éducation physique de McGill d'octroyer 2 bourses chaque année à des étudiants promoteurs de cycles supérieurs dont les travaux sont axés sur une santé active. I'm very proud, actually, to tell you that we have the winners with us today. And this year's winners are Vita Sonjak and Ricarda Hager. Vita is a first-year PhD student who, under supervision of Russell Heppel, Dr. Russell Heppel, is studying the mechanisms behind progressive muscle loss with aging and whether males and females are affected to the same degree. Ricarda is a PhD student in the muscle physiology and biophysics laboratory that I happens to head up. And with the help of atomic force microscopy, she's studying the biophysical properties of single muscle molecules and fibers to perhaps help the prevention of cardiomyopathies that affect the cardiac muscular system. So congratulations to both of you. Now, it's time to, I've said enough, it's time to turn our attention to the winner of the 2015 Bloomberg Manulife Prize for Active Health, Dr. Lora Giangregorio, who will participate in a question and answer, like Jill has said, hosted by our guest moderator, Jill Barker, and by Ricarda Hager, one of our students who won the award this year. Dr. Giangregorio is an associate professor in the Department of Kinesiology at the University of Waterloo, and is a highly respected authority on osteoporosis with research that's having a significant impact in the development of safe and effective exercise regimen for millions of women and men, as she'll tell you if you have questions about gender issues in osteoporosis, people who are at risk of having osteoporotic fractures. Like me, many of you will be surprised to learn that the frequency of osteoporosis relates bone fractures is way higher than the incidence of heart attacks, stroke, and breast cancer combined, actually. It's a very challenging problem that we have, and the annual cost to the Canadian healthcare system for treating those with the disease is actually estimated to be $2.3 billion a year. The overreaching goal of Dr. Giangregorio's research is to improve the assessment and treatment of osteoporosis through an emphasis on effective and safe physical activity. She has collaborated with an international team of experts to create the 2 Fit to Fracture guidelines, a radical new set of physical activity strategies that address common misconceptions about what's safe in terms of movement for individuals with osteoporosis. She's a member of the Scientific Advisory Council of the Osteoporosis Canada, the Canadian Society for Exercise Physiology, and the American Society for Bone and Mineral Research. So, ladies and gentlemen, please welcome Dr. Lora Giangregorio to the podium. Thank you very much. So, I'm just before leaving the stage, I'll thank you, Dr. Giangregorio, for sharing her time with us today, and also thank Jill and Ricardo for what they are going to do right now. So I guess Jill will come up now to help with the...
Okay, time to get started. Ricky will take the floor first. She'll have about 10 or so minutes to pose a series of questions. I'll follow, and we'll get started. Way to go, Ricky.
So I was wondering, since your approach to osteoporosis is an exercise treatment, what is the kind of benefit from an exercise treatment over a traditional treatment with medication or a drug treatment?
Well, I think if you're diagnosed with osteoporosis, both are important. So I wouldn't necessarily say that you would choose one over the other. If you are at risk of future fractures and your physician says that you should be on medication, then that's or that suggests that you be on medication, then that's something you should consider. But I think that whether we want to prevent bone loss or whether we want to prevent fractures because we have osteoporosis, or even if we don't and we want to prevent it from happening, it would be important to also include exercise. And so if we think about fractures or broken bones, they often occur as a result of some sort of applied load or a force that is applied to the bones. And so with medication, what we do is we try to increase the bone strength so that the bone is more resistant to those loads. And with physical activity, we can try to prevent bone loss from happening, and that will also hopefully maintain the bone strength. But the interesting thing is we can also, with physical activity or exercise, try to prevent falls or try to have better posture, so that reduces the loads on the spine. And if we prevent falls, we're preventing the applied load from happening. So it's both sides of the equation. So a fracture occurs because the applied load is greater than bone strength. And with physical activity, we can try to maintain or improve bone strength, but we can also try to prevent the applied load. So we can try to two different strategies with one treatment, which is great.
So I at least know a lot of people that are already struggling to keep up with general physical activity. So what are ways that you make it easily accessible for people to kind of incorporate the exercise regime that you're suggesting into their daily lives?
So I think the types of physical activity and the exercise that we recommend are not that different than Canada's physical activity guidelines, and they would also have many other health benefits. So it's not that we're trying to add a whole bunch of other things. We're just sort of trying to tailor what people do. So for example, we would recommend that Canada's physical activity guidelines recommends a minimum of 150 minutes a week of moderate to vigorous physical activity, broken up on most days of the week, so roughly 20 or 30 minutes a day. And that's a minimum, and if you do more, you'll have more health benefits. And our recommendations are very similar. The only difference that I would say is if someone has osteoporosis or if someone's trying to prevent bone loss, we might recommend that they choose some activities that involve some impact to the bone. So like if you're walking, you have an impact on your legs or on your feet, right? So your leg bones, or if you're running, or if you're jumping, or if you're dancing. And also, if someone is at high risk of fractures, so if they have spine fractures, for example, we might recommend moderate over vigorous physical activity, because vigorous physical activity usually involves high impact. And that's where we worry a little bit that the risk is going to outweigh the benefits. Of course, it's an individual decision, and everyone needs to think about what they're able to do and talk to a physician or healthcare provider. But in essence, the recommendations are very similar. So if we want to try to then have people uptake those recommendations, you want to think about the things that are going to influence behavior change. So making a plan. Right? So, for example, the recommendations suggest doing resistance training at least twice a week, or strength training at least twice a week. And so if you just say to yourself, well, I'm going to do more strength training, you're probably not going to do it, because it's not a specific enough goal. But if you say, okay, well, I need to learn how to do it, so I'm going to make an appointment with a personal trainer, or I'm going to go to the YMCA or the gym that I go to, and I'm going to do it on Tuesdays and Thursdays. And then if you could even be more specific and say, I'm going to get up in the morning and I'm going to go at 8 o'clock in the morning on Tuesdays and Thursdays, and I'm going to do these exercises for this long. All of a sudden, you've got a plan that's very specific, and then you're probably more likely to stick with it, especially if you then bring in triggers or you make it a habit. So if it's something that you do with a friend every week, or if it's something that, let's say you don't have the time to go to the gym, or you're not ready yet to go to the gym, but you make it a trigger. Every time when I'm watching TV and the commercial comes on, I'm going to do 10 squats. So there's a trigger there to remind you to do it, and then it becomes a habit. Or every time I'm waiting for my tea, I'm going to do push-ups on the counter. Some sort of trigger that helps you make it a habit. That's how we actually try to help people change their behavior. We think about how we can make it a habit, how we can have a plan, and it's a specific plan. And then also thinking about contingency plans. So if you have a plan to go to the gym every Tuesday and Thursday morning, and then one morning there's your friend invites you out for breakfast and you can't go, instead of just saying I'm not going to go, say, okay, I'm going to go on Thursday instead, and say that have an alternate day. So the idea that you have a plan that also has contingency plans. So we want to emphasize aerobic physical activity, resistance training, and balance training. We want to have a plan to do that.
And then I was wondering, after all this is over, what are some of your new projects or next steps? Do you want to develop your program further? Or?
That's a really good question. I have a long list, and I'm still trying to narrow it down. So there's a few things that I'd like to do. So one of the things is doing exactly what you asked me about. How do we actually help people use this information? And I think I'd like to take it a little bit more broadly and say, how can we better have both patients and healthcare providers use this information and make it part of routine. And so perhaps we can think about finding ways to make it part of our healthcare. So why shouldn't a physician, when you go in for your checkup, check your physical activity level just like they check your blood pressure, right? Or why shouldn't physicians learn a little bit about exercise and physical activity counseling as part of their training? Or perhaps we need to do a better job of helping people assess themselves in terms of their physical activity and connect them to the resources that exist in the community. So can we do some research around better integrating that type of thing? And the other thing I'm really interested in is understanding how the types of interventions that are best for bone to adapt to, or the types of interventions that target bone, and what things might modify that. So one example is people often focus on walking as an exercise, and what's the added value of adding resistance training? Does it actually really do a better job? Does it increase your bone mass more, or is it just affecting your muscles? And then are there things that might modify that effect? So for example, does it work better in younger people than older people? Are older people more resistant to, do their bones respond as well as people who are younger? So if you compared a 60-year-old to an 80-year-old, for example. Or is something like nutrition an effect modifier? Is it going to modify the effect? So if we give protein supplementation and resistance training, is that going to have more of an effect on muscle and bone than just doing resistance training? So there's lots of questions that I'm really interested in answering. So I'll just have to work on narrowing it down.
Sounds very exciting. Okay, that's it for my questions.
Yeah.
Thank you. All right, my turn. So I'm confused. Does exercise, does it build bone, or does it just keep us from losing bone?
So I'm going to take a step back and say what happens to our bone through our lifespan first. So our bones. So we develop and build most of our bone mass in childhood and adolescence. So you reach your peak bone mass sometime in your 20s. And then usually what happens is you kind of come to a plateau, and then it's up for debate, but starting in your 30s and 40s, you start to lose bone mass, and that happens gradually over time. And so that's why the prevalence of osteoporosis increases with age, because the bone loss also increases. The amount of bone we've lost increases with age. And then superimposed on that, if you take a medication that affects your bones, or if you have a disease that affects your bones, or if you happen to go through menopause and you have reduced estrogen levels, that will then also cause bone loss. And so if you superimpose these, I guess, stressors or experiences onto the age-related bone loss, someone might develop osteoporosis or lose bone mass earlier in life. And so if we think about, does exercise affect bone, it depends on when you're applying it and what else is going on. So if there's some research to suggest, for example, that bones are more responsible before puberty than after puberty. That you can actually build more bone mass if you apply an exercise program before puberty. But there's also some research to suggest that we might be able to maintain bone mass in adulthood. Some suggest there are studies that show a positive benefit of exercise with respect to bone mass. So the exercise group's bone mass is better than the control groups in adulthood. And where we're not really sure is in much older adults. A lot of the studies are done in younger people. And by younger people, I mean like 60 as opposed to 80. Right? 60's not old. 80's not old. 80 can also not be old. It depends on your attitude, really. But anyway, and the other thing is that what makes things tricky is if you're on a medication that affects your bone metabolism, they often kick you out of the study. And so as people get older, they're more likely to be diagnosed with osteoporosis and then put on a medication. And so a lot of the studies have actually excluded those people. So we don't know, can we build bone in those people because they're on these medications that affect their bone metabolism. So it's hard to answer that question broadly. Like, can everybody increase bone mass? Perhaps some people can. Perhaps some people can maintain their bone mass. And perhaps some people can make the loss slower. And it really depends on the age that they are, the type of exercise that they're doing, how intense it is, and also whether or not they're on any other medications or other things. So hopefully that clears up the confusion for you.
A little bit better.
Yeah.
So let's go that a little bit further. I'm a runner, but I swim and I cycle. So how, like for someone who doesn't have a lot of either exercise, a paddler, a swimmer, a cyclist, doesn't have a lot of impact stress, how do they, how should they modify their workout, or do they need to?
Yeah, there's some studies that show, so they don't actually take runners and then take people and get them to run and then see what happens, but they take a bunch of people who run a lot and compare them to people who don't run a lot, or swimmers. And they actually find that people who run long distances or do a lot of swimming and even cycling, they sometimes have lower bone mass. And part of the reason for the cycling and the swimming, they think, is because they're not loading their bones as much. The running's a bit complicated because some people who run a lot also are very careful with their weight and have really low body weight. And so sometimes it's a combination of, they are getting the impact loading, but then they also have, they maybe are not getting adequate nutrition, or their body weight is really low, and that puts them at risk. Or they might just be a person who happens to be genetically have a thin frame, and therefore they do really well at running, and therefore, but they're also genetically predisposed to osteoporosis. So it's a bit complicated. But I would say that for everyone, diversity is important, right? So I think in all of our exercise programs, we might think about challenging all of our body systems in different ways. So yes, I think running is great. I do like to run, but I also want to think about how else can I challenge my bones. So maybe I'm going to do resistance training, and maybe every once in a while I'm going to do some unusual movements in my, so maybe I'm going to be running on the track, and then at the end of my workout I'm going to do like side steps or side lunges or other types of impact loading. And then my bones have to wake up and say, wait, what's going on? Like, we just did something different. We got to adapt to that, right? So I think if you, to be able to make change in a body system, you have to apply a stress. You have to do something that's different, right? So if we're resistance training and we want to build strength, we have to try to lift something that's hard to lift. If you lift something that's easy to lift, your muscles don't need to adapt and get stronger. So with resistance training, we want to pick a weight, for example, that we can do somewhere between 8 and 12 repetitions. So if we can do less than 8, it's probably too hard. If we can do more than 12, it's probably too easy. And then we get to the point where we're lifting it, we're at about 12, and it's kind of hard to lift, and then we create a little bit of muscle damage, and that's when our muscles have to wake up and say, wait, we can't lift that very well, we better get stronger. And the same is with our bones, so we need to do things. You know what has really good bone density is soccer players. And that's because they often have to run rapid changes in direction, and they're going laterally and sideways, right? So they're doing things that are different than what they do every day in walking, right? So if you're out running, do your running, but then maybe add in something different, like walking lunges or lateral lunges or grapevine step movements or things like that that can maybe add some variety, or take a Zumba class, right? And do something different, move differently. Does that help?
That helps. So if I newly found out that I have osteoporosis, or I'm at risk, is my GP the best person to get exercise advice from, or how do I get that advice?
I think talking to your GP is a great first step, because your doctor is going to help you identify what your level of risk is, and that may inform your decision making. So someone who's been diagnosed with osteoporosis or low bone mass but has no other risk factors may be able to do all the activities they want to do safely, and they can start an exercise program no problem. If I have someone who has been diagnosed with osteoporosis and has a spine fracture or has other risk factors that would otherwise classify them as high risk, then the choices that they make in their exercise program may be different. So it's important to have a discussion with your physician about what your level of risk is, and are there any things you should be careful of. And then maybe even talking to your physician about who they should see. So someone who's high risk, I would probably say, probably should see a physiotherapist with some training in osteoporosis to guide their safe performance of everyday activities as well as their exercise program, whereas someone who is lower risk might not necessarily need that level of therapy, I guess. So starting with the family physician, but then going to perhaps a clinical exercise physiologist or a kinesiologist or a physiotherapist or someone who has training related to exercise prescription for osteoporosis.
And are there any exercise activities or exercises themselves that you would not recommend for anybody whose bones are at risk?
So I wouldn't necessarily pick specific exercises, but rather think about the types of movements that you'd want to avoid. And then you can think about all the exercises that might fit that, or even the daily activities that might fit that. So the types of movements that we think are a bit more risky, and arguably probably risky for everyone's spines, but particularly for the spines of people with osteoporosis, are those that involve flexion. So when, I'm going to stand up just so I can show you what I mean. So when you flex the spine, right? So not flexing the hips, but flexing the spine, as well as twisting movements. And not just all flexing and twisting, because it's kind of hard to get through a day without flexing or twisting. So we're not suggesting that people walk around like robots. But the idea that if you're rapidly flexing or twisting, or you're repetitively flexing and twisting, or you're flexing and twisting while you're holding something heavy, right? So let's say you pick up a grandchild and then do this, right? That would be a problem. Or holding something far away from the body. Or flexing and twisting all the way to end range. So I'll give you an example. There was a woman in one of our studies who had a spine fracture, so she was high risk, and she bent to tie her shoes and fractured a vertebra in her spine because she bent all the way down like this. Right? So she's bending all the way down or twisting all the way around. So we think about applying that to exercises. There's certain exercises, like have you ever seen the ab machines where you have to crunch like this, right? Those would be flexion that's repetitive. So instead, you could do a plank exercise to activate your core without actually doing that flexion. And there's some twisting. So I love yoga. I think it's a great practice, but there's certain yoga movements. So for example, there's one where you have to sit and then you have to cross your legs and then twist into a funny position. And that might not be the best position for someone with osteoporosis because you're sitting, so you're loading the spine, and then you're also applying a twist all the way around, right? So instead, they could lie down on their back, so they're unloading their spine and do a gentle twist if they wanted to work on mobility. So it's thinking about the types of movements that are risky and then thinking, what are the things that I might do that have those movements and how can I modify them to make them safer?
And how much time do you think a week it will take to, someone can devote to not only meeting the Canada's physical activity guidelines, but also the guidelines related to osteoporosis?
I would say that they're fairly similar in both time and goal, so I don't necessarily think you need to add a lot of time. The only thing would be to paying attention to your ability and matching your ability to, say, the intensity of the activity and also the goal of the activity. So one thing that our guidelines emphasize more than Canada's physical activity guidelines is the importance of balance training and the idea that we should frequently challenge our balance. We don't often realize we're losing our ability to maintain balance until we start falling. And even then, people say, well, I'm using my walker, I'm being more careful, so therefore I'm not at risk, right? And it's not always something you have as much control over because you usually fall when you're exposed to a stressor that you were not anticipating. So it's, I think, important to train your body to be able to respond to those stressors or those things that create a risk for falls. So, and it doesn't mean you have to add a whole balance training regime. It just means thinking about ways to challenge your balance, either including it in your daily life or adding it into your exercise routine. So a good example is if you'd all like to come to Waterloo during Oktoberfest, you could come and do some polka dancing. And polka dancing is great cardiovascular exercise, but it's also a balance challenge, right? Because you have to go from one foot to the other and spin around in circles, right? And you're shifting your body mass around. So the idea that you can choose aerobic physical activity or resistance training exercises that also challenge your balance. So just being smart about your exercise as opposed to trying to plan out this really long exercise regime. So walking lunges or lunges challenge your balance. The Zumba class, again, you know, you're moving with unusual movement patterns. That's also going to challenge your cardiovascular fitness. So just being smart about and making sure that you're trying to challenge all of your body systems, your cardiovascular system, your muscles, your bones, and your balance.
Great, thank you very much. So now we're going to turn the floor over to you. We've got 2 microphones. We welcome people to take their turn at the microphone. We do ask that you limit your questions to 1 and that they're short. And then after you've had your single question answered, if you want to go down to the back of the line, we'll welcome you again. And if it gets a bit long, I may cut you off gently and politely, of course. Away you go.
Our researchers have given us valuable information about how to maintain or improve our health. My question, though, is who studies the reasons we don't do the things we ought to be doing and how we can change those?
A lot of people do. That's a great question. So we actually did that. So we went out and we spoke to 550 patients, physicians, physios, around what are the barriers to implementing exercise guidelines. And we have a long list of barriers. And some of them have to do with people's knowledge. They don't know what exercises to do. Or some people's capability. They don't feel like they can do it. They don't know how to do it. Some of them they talk about opportunity. So they talk about, I don't have access to a gym. I don't have time. I don't have, it costs too much for me to get the advice that I need. And then some of it is just a motivation thing. Some people just honestly admit, I am not interested and I'm not motivated to do it. Or the physicians might say things like, well, you know, my patients are not motivated, or I'm not motivated to teach them because I don't have the time, or I don't have the knowledge to be able to do that. So there are lots of reasons, and I think we do need to do a better job of thinking about strategies to change people's behavior. But the first step is saying, what do we want them to actually do, which is what we've done with our recommendations. And now we're working on things to help people change behavior. So a few examples of what we've done to do that. So for example, the physicians said that we talked to, not all physicians, but the physicians we talked to, a lot of them said, I don't have time to counsel my patients on exercise, and frankly, I'm not comfortable in my level of knowledge to know what to tell them. And so what we worked with them to do was develop a one-page summary of the exercise recommendations that has a few pictures, and it also has links to the Osteoporosis Canada website with lots more tools on it that they can then give to their patients to help them at least take, you know, here's information on the recommendations and here's where you can get more information. And that's what they were willing to do. And then the patients, a lot of them said, you know, I just want to see, when you say lunge, I want to see how do I do that? And I can't afford to, you know, go to a gym, or I just want to do it at home, so I need someone to teach me how. So can you just, you know, find ways to do that? So what we did was, oh, and the other thing was that everybody's different. So I can't say, here's one exercise program for everyone to do, because everyone is different. The exercise program I'm going to give to a, you know, healthy, you know, 48-year-old woman who had early menopause and now has osteoporosis is very different than the exercise program I'm going to give to the 90-year-old who has 3 vertebral fractures and uses a walker. So what we did was we identified, you know, 4 example faces of osteoporosis, and we have a video that tells their story, and then 2 subsequent videos that shows their exercise program and how to do the exercises with instructions. So a person can then go on the website and at least get that information. Now, is that going to make the world all start exercising? No. But at least it starts to break down some of those barriers around people. I don't know what to do. Their doctor can say, look, there's some videos. You can try this out. We also developed some planning tools, which we're still working on, that we're going to make available that can help people write out plans. The other thing we did was we trained over 400 physiotherapists and kinesiologists across Ontario around the information, so that they can then share the information with their patients and become advocates and try to help their patients. So we're working on it, but I'm sure there's lots of work to do, and there's some health psychologists here that are doing similar work. So you can bother them to get on that.
Thank you.
Yeah.
In the back.
Hi. My question concerns medication.
Can you come closer to the mic because I can't hear you?
Sure.
Oh, thank you.
Better?
Yes.
My question concerns medication.
Okay.
So two kinds of medication that I'm asking about. One is one that might cause osteoporosis, and the other is one that might prevent it. So the
Okay.
one I'm talking about first is Arimidex.
Which one?
Do you know Arimidex? So
familiar with that.
it's a hormone blocker
Okay.
that many breast cancer patients
Yep,
are
yep.
prescribed post-treatments, etc.
Yes.
And it's supposed to cause osteoporosis. So
Yes.
there's all kinds of preventive things, et cetera, but it's, so I'm on that drug.
Yes.
And I'm otherwise quite healthy, very, very active. I eat well. But doctor has indicated that I should probably go on something else called Prolia. Do you know about
Yes.
that? Yeah, so that's supposed to prevent osteoporosis.
Yep.
But I understand there are many side effects with it, and so I'm trying to avoid that. Other than that, I feel great and exercise, as I say, and do all the right things. So do you recommend?
So I can't make recommendations for you, and certainly your doctor has made a recommendation around the medication. And so I guess I'll put it in perspective. Like, there is knowledge that we know that those drugs cause bone loss. It's kind of like similar to how menopause causes bone loss, and how other types of medication cause bone loss. So that medication basically tells bone cells to not break down bone, and so it's going to prevent the bone loss from happening. It's hard for me to say, if your doctor thinks that it's something that you should take, then I hesitate to say you shouldn't take it or argue with your doctor. And I'm not a physician, so I can't make those recommendations.
Yeah.
But I can say that medication has been shown to reduce bone loss and also reduce fractures. So it's not just that it affects your bone density, but there's actually data to show that it actually reduces fractures and does so very effectively. There are side effects. There's been 2 different side effects that have been in the news, but they're very rare. And so usually when physicians make decisions like that, they will weigh the risks of the medication versus the risks of not going on the medication, and they'll make decisions accordingly. And so it sounds like your doctor thinks that the benefits will outweigh the risks. And the risks are rare. Like the risks of the side effects you're talking about are quite rare. That's related to that. So yes, that drug that you're talking about will cause bone loss. Yes, the drug you're talking about is very effective for preventing bone loss and or preventing fractures.
Can I ask you another question?
Yes.
How does one tell if they have osteoporosis? I mean, are there like
The
signs?
only symptom is fracture?
That's it. So you don't know, you don't feel achy or?
No.
Okay.
No,
Just
so you can be losing, your bone is actually turning over all the time. So your bone cells are breaking down bone and refilling bone all the time. And so what happens in osteoporosis is more bone is broken down than is being rebuilt. And it happens in little pockets all over your bone, so it's so small that you wouldn't feel it. It's not something that and so you can have osteoporosis and not know it. In fact, many people do. And unfortunately, once you have it, it's really hard to build that bone back up. So your doctor's trying to prevent it from happening by prescribing that medication. But yeah, you won't know until you have a fracture.
Thank you.
Frank.
You touched on...
Sorry, it's in the front. We'll go to the back after. Sorry about that.
It's interesting. Me and the previous speaker are octogenarians, and I know he doesn't exercise. I play hockey for the last 75 years, and
Good for you.
I give you a little chronology. I haven't exercised. Vic Tanny's. You heard of Vic Tanny's?
Sorry?
Vic Tanny's. It's an exercise place.
Okay.
I used to go there, and for after work.
Yeah.
jump in the water, pump a little bit of iron, and run home, feel good.
Vic
Go for a swim.
Vic Handy's in the town I used to live in was a bra store, so I got a little bit confused for a second.
Vic Tannies.
Yeah, I know. I was like, wow, you do your exercise in interesting places.
Anyways, they suddenly closed down, and I says, so I was worried more about my soft tissues than my bone.
Okay.
And then I played old-timers
Everybody's always
hockey.
worried about the soft tissues. Bones are important.
Well, that's why I play hockey, sort of thing. But I was in Brockville. I remember playing hockey in a tournament, and they were giving free bone density tests. Okay?
Really?
Yes. And
Was it like your ankle?
10 years ago? No, it was my arm.
Arm.
They just
okay.
had. Yeah.
It was probably an ultrasound.
Anyways, they checked I was 70 then. That was 10 years ago. And what happened was, they said I got bones of a 50-year-old. So I said, I guess that's okay. I mean, I drank a lot of whatever you're supposed to drink when you're young. But since then, I've been still playing hockey because it's the only exercise I do.
Okay.
And I'm just wondering, arthritis sets in a little bit, and what is there any? I could go back and exercise, but I'm scared of doing the wrong exercises. I got to be careful of not overdoing it. So how should I start? I mean, I can't walk because I had a mining injury. So I play hockey. That's why I play hockey. I can't walk.
Yeah.
You put it in a boot and away you go. So what could what would you suggest?
It's hard for me to say what you should do because
Or
I don't.
In general, I mean, I know arthritis sets in after a while to everybody that gets our age.
So the interesting thing about arthritis, knee osteoarthritis, is what I'm assuming you're talking about.
Well,
or hips or shoulders, something.
It's near the spine.
Okay, in the spine. So the interesting thing about arthritis is it causes a lot of pain, and yet there's research to show that exercise actually improves or reduces pain. And some of that, I think, has to do with the fact that we are becoming more mobile and getting less stiff. And some of it has to do with, so for knee osteoarthritis, if we can actually build muscle strength, we're actually building tissue to help take up that impact so it doesn't hurt as much. So I definitely would certainly continue to exercise despite the fact that you have arthritis. And I think the first thing that we need to think about when we're choosing an exercise program is what is something that I'm actually going to do? I'm not going to pick something that I don't really like doing or that I'm probably going to stick with. So pick something that you're going to stick with. Pick something that suits your abilities. So if your doctor doesn't think it's safe for you to play hockey anymore, that's a different story. If you can do it safely within your health and ability, then you do that. The second thing is, what are your goals? So if your goals are to improve strength, you do strength training. And if your goals are to improve your cardiovascular fitness, you do aerobic training. Ideally, you do a little bit of all of those things. So I think it's just selecting exercises that you can do that fit that. I don't know if that helps.
Yeah. So osteoporosis is not on my schedule if I haven't got it by now, is that right?
Not necessarily. I can't say whether, I don't have x-ray vision, so I can't tell whether or not you have osteoporosis. And the machine that they probably tested you is an ultrasound, so it's probably not sort of the test that they would do, that a physician would do. I think anyone who's over the age of 65 should have a bone mineral density test. So if you haven't had one, you can say to your doctor, you did say you were over 70, so you would qualify based on our healthcare system for a bone mineral density test, and then you could get that information. But it sounds like you've been very active, and I think just finding ways to maintain that activity. One thing that happens when we get older, we don't just lose bone mass, we lose muscle mass. And it's a lot harder once we get past 80 to actually increase our muscle mass. So one thing you might think about doing is building, trying to build a foundation of muscle mass so that you have a reserve. So then as you start to lose it as early as your 40s. So you want to try to build as much muscle mass as you can. So maybe that's what you need to add is some strength training.
Well, I call my abs, I call them molten muscle.
Okay.
Thank you.
Greg. In the back, please.
Yes, you just said something about bone marrow density. Is that the same thing as bone density?
No.
In terms of, it's not, eh?
No, bone mineral density.
Oh, bone mineral density.
So
Okay.
people say bone density, but the actual appropriate term is bone mineral density because you're actually you're not measuring the true density of the tissue, you're measuring the mineral density. Okay. It's a technical
accuracy thing.
My question to you is, you touched briefly on the hereditary aspect of bone health. And I'd like to understand, if you are predisposed, does that mean that you can do something to better your bone health, or does that mean you're kind of in the bad luck category?
I think that with anything, there's often, for many diseases, there's an interaction between genes and environment. So I think that you certainly can be predisposed to it and be at higher risk. But if you do your best to modify the modifiable risk factors, that's the best you can do, because you can't modify the genetic risk factors. And if you don't do that, so if you're at risk, if you're genetically predisposed and you don't pay attention to your physical activity and nutrition, maybe you might develop osteoporosis earlier in life, or you may fracture earlier in life. And the other thing is, back to the whole applied load versus bone mineral density. You may be genetically predisposed to have a low bone mineral density, but you might not be genetically predisposed to falling or to having low bone muscle strength, or all of those other things that might influence your fracture risk. So fracture risk is a different thing than risk for low bone mineral density. So I would argue that yes, you absolutely can modify your risk of falls and your risk of losing muscle with age, and all of those other things, your posture and all of those other things. So those are the things that I would target, because those are the things that are modifiable.
Okay, thank you.
Great, in the front. Hello.
Hi.
Just from a prevention aspect for bone loss, but from a nutritional standpoint.
Okay.
There's a lot of contradictory information with regards to whether we should increase dairy products or non-dairy products, or supplements, calcium, vitamin D, all this stuff. I don't know if you have any information with regards to that.
So I'm going to preface this with, I'm not a dietitian, and this isn't my area of research, but I know a little bit about it. So if I say something that offends a dietitian here, please, I'm sorry. Osteoporosis Canada's position is that we need to get adequate calcium, not more than adequate, and that we should try to get most of it from food. So some of the headlines around getting calcium and it being risky pertain to calcium supplementation. So most of the studies that have shown these potential risks are all in studies where they've taken calcium supplements. So I think that if you try to get adequate calcium from food, so adequate being, I believe it's 1,000 milligrams below the age of 50 and 1,200 above the age of 50 per day. So if you try to get most of your calcium from food, then that's the best strategy. In terms of the dairy product issue, there are other sources of calcium. So if consuming dairy products is something that you're not comfortable with, either morally or because you think that there's risks associated with it and you want to avoid that, you can get calcium from other sources. You just need to pay attention to what you're eating. So there's fortified soy milk, there's fortified orange juice, there's almonds, there's all kinds of other sources. So what I would suggest is going on to Osteoporosis Canada's website. They have a calcium calculator. You can actually put in the foods that you eat in a day, and it'll tell you how much calcium you're getting, and then you can say, do I need to make some changes, yes or no?
Thank you very much.
You're welcome.
In the back.
Oh, the other thing is vitamin D and protein. So vitamin D is something that we can make in our skin with exposure to sunlight. The sun's not high enough in the sky between the months of October and March in Canada, most of Canada, so many Canadians become deficient. Taking too much vitamin D is not a good idea either, so you can check Osteoporosis Canada's website around the amounts of vitamin D that you should take, and some people suggest taking it as a supplement in the winter, and that's something you can suggest to your doctor. I think protein intake is something people ignore. There's new research to suggest that the recommendations of 0.8 grams per kilogram body weight per day are not sufficient, and that we should actually be having closer to 1 gram to 1.2 grams per kilogram per day of protein, and that we should divide it up through the day, and that in fact getting a bolus of protein in the morning is a really good idea. And if you think about it, it makes sense, right? When you go to sleep at night, you're not eating for 8 to 10 hours, depending on how long you sleep, or 12 hours. And so your muscles are building, you have muscle protein synthesis or building muscle, and you have muscle protein breakdown happening all the time. And so a lot of that has to do with how much protein you have available to yourself and how active you are. So if you think about it, you're essentially starving yourself all night, and then if you have tea and toast for breakfast and don't eat protein until lunchtime, there's a whole window of 6 hours where you don't have any protein, and that might actually cause you to break down more muscle than you synthesize. So having a good chunk of protein in the morning, doesn't have to be a chunk, but consuming some protein in the morning might actually be a good idea to try to prevent muscle loss from occurring.
Okay, thank you very much.
Great. In the back.
Hello, my question pertains to what you discussed prior, the bone mineral density test.
Yes.
At what age do you recommend that this test be done?
I don't make any recommendations, but the way that Osteoporosis Canada phrases it, no, I'm making it clear because I want to make sure this is not my...
Yeah, but what is your research showing?
So Osteoporosis Canada guidelines suggest that everyone who's over the age of 65 should have a bone mineral density test. And those who have risk factors, so if you're 50 but you have risk factors, like you have had a fragility fracture. A fragility fracture is a fracture that occurs during an event that wouldn't normally cause a fracture. So if I walk across the stage and I trip over that cord and I reach out forward, break my wrist, I shouldn't probably have broken my wrist in an event like that. So having a fragility fracture, having early menopause, having a condition that affects your absorption of nutrients like celiac disease. Some of those conditions might warrant an earlier bone mineral density test, and that's a decision that's made with a physician. So you can have a bone mineral density test if you have those risk factors, but it's not really a good use of our health system dollars to test everyone when they're young, because most people wouldn't be at risk. So it's identifying people who have risk factors and doing a test, or just testing people over the age of 65.
One risk factor that we often see in practice is young women who have had anorexia or bulimia.
Correct.
And often they kind of slip through unless they fracture.
Yeah, actually I had a friend in university who was diagnosed with osteoporosis in her 20s. And they didn't really know. The problem is that we can diagnose her, but other than adequate nutrition, there's not really medications that they're giving to people who are that young.
Yeah. Thank you.
Yeah.
Last question in the front.
Thank you. I'd like to ask about the flexing and twisting you said that was not recommended. I've been an avid cyclist, walker, and cross-country skier all my life, but it's always the same movement, and I've never gone to a gym until just now. And I've been diagnosed as osteoporosis in the lumbar area of the spine. So I've just started with a personal trainer who's got me doing flexes, and I've been doing yoga for years, and we always do the twists, and it always feels good. So it was a shock for me to hear that you don't recommend it.
So this is where the recommendations, and part of our recommendations, so I didn't get into, is they vary based on clinical presentation.
Okay.
So so it's not just what your bone density is in your spine, but what your fracture risk is in the next 10 years. So you look fairly young. And
62.
Right. So if I have someone who is, so what you might want to ask your doctor is, what is my fracture risk?
Okay.
Because the way that Osteoporosis Canada guidelines is now recommending is that we look at the person's bone density, their age, their gender, their other risk factors, and determine a fracture risk. Are they low, moderate, or high? Because you may have a person who is young and has low bone density but no other risk factors, and they may actually be at low risk.
Okay.
Right? In the next 10 years. But when you ask again, and if you have the same bone density at 80, your risk is automatically higher, because older people are more likely to fracture, because they're more likely to fall, because of a whole bunch of other reasons. So understanding your fracture risk, not just your bone density, is important. And that may modify the recommendations. So if I had someone who had osteoporosis based on their bone mineral density, had no other risk factors, was very healthy, was already doing an activity with no problems, I might just say, do the yoga. When they're doing the forward bends, like the forward fold, put your hands on your thighs to support your trunk.
Okay.
Or, so I'm not saying you can't do it. I'm just saying I might make some small tweaks. Or instead of doing the sitting twist, don't twist all the way around, or maybe modify it and do it in supine, like laying down. Sorry. Right? So I'm not going to say don't do it. If you had 3 vertebral fractures, my recommendations would be very different. So it's thinking about who you are, what you've done before. What is your current health? What are your risk factors? And then I have to modify. And that's what a good exercise physiologist or a physiotherapist who has that training can do. If I had to make broad recommendations, I would say we want to avoid rapid, repetitive, weighted end range twisting and flexion. But on an individual level, we have to be able to make good decisions based on what's in front of us.
Okay, thank you.
Does that help?
Yeah.
Thanks.
All right, Barb, you persuaded me.
Thanks,
One
Jill.
more.
Did your research reveal any differences between men and women, how well we respond to exercise, and whether or not we need to modify our exercise depending on our gender to increase our responsiveness?
I can count on my hand the number of clinical trials looking at the effects of exercise on bone density in men. So there's not enough research for me to make good decisions. Whereas there's quite a few more in women, most of them done in postmenopausal women, but there are some done in younger women as well. I am not aware of any major differences in their responsiveness to exercise. It's possible we may see some differences in the way bone shape adapts or mineral density adapts. Certainly there's probably some differences in the way muscle adapts as well. I anticipate there would be differences. I can't articulate them in a way that would, or I can't make any definitive, yes, men are going to have a better bone density response than women are, because I don't think that we have enough research. I don't know if that answers your question.
Thank you very much, it does.
Yeah.
Thank you very much. I'll turn the floor over to Dean Razier to close it out.
Thank you, Dr. Giangregorio, for sharing your time with us. Thanks, Ricarda, Jill. It was a very interesting panel. We learned about osteoporosis. We learned about exercise, even about some interesting places to go and do some exercise. So I would like to invite, actually, the three of you to join me here so I present some small gifts as tokens of our appreciation.
Thank you.
Thank you.
Thank you so much. Thank you.
I think he wants to do
Thank
it.
you.
Just before we finish, just a quick reminder before you go. If you have not yet signed up for the e-digest called Ideas That Move You, please do so. This is something prepared here at McGill. It's an electronic publication that is delivered right to your email inbox, providing information and tips about healthy living, and it's totally free. So I do recommend that you sign up if you haven't done so. It's very interesting, and that will conclude our event. Thank you very much for coming, and please have a great afternoon. Thank you.